I'll admit everyone.
Yeah, if you let everybody in for us, that'd be great. Okay. So we have people in now, I think. Yeah, cool. All right. Should we get cracking then?
Yeah, by all means.
All right, guys, brilliant. I'm going to try and keep this within the time limit as well. So hi, my name's Tim. I'm one of the physician associates at Wythenshawe Hospital's cardiology department. And I'm going to give you a bit of a session today on some ECGs. So this is really hopefully stuff that you guys should already know around third year level. I just really try and consolidate it. But let's get cracking anyway. So if I can get this working, there we go. Right, so hopefully everybody can see the screen now. It should say aims, etc. Can everybody see that? Is that right?
Yeah, we can see that.
Excellent, brilliant. So what would be good, guys, is so what we're going to try and do is go over basic ECG interpretation. It's obviously the starting point here to make sure you know a process of reviewing an ECG, have a system for interpreting some tachyarrhythmias, which is what we're going to go through, and to try and recognize some of the common ones as well. We're not really going to be able to cover all of them in this session, particularly as I'm hoping we're going to get you guys to just have a go at yourself, but we'll try and look at some key ones here and also try and get a bit more understanding about, a little bit about the pathophysiology and management. But really, I want you to recognize that's the aim of this session. Okay. So I have an ECG here. It's basically the simplest one of the night. So it'd be really easy, really good if somebody would actually like to have a go at just trying to tell me your process of interpreting an ECG. So you don't really want the diagnosis. I just want you to talk me through how you interpret an ECG. Does anyone want to have a go at that?
I don't mind starting us off.
Yeah, that'd be great. Talk me through.
Yeah, so my general process and what I've been taught and tend to do is, I like a systematic way. So first of all, you might look at the patient details, make sure it is the right patient. What time was the ECG taken? Do they have previous ECGs that you can compare it to? That's always very helpful. And then getting into the actual interpretation itself, so you can look at the rate, the rhythm and the axis, and there's sort of multiple ways to do that. And then once you're quite happy with those three things, you can start to look at things a bit more specifically. So the waves, for example, so you might look at the P waves, QRS, are P waves succeeded by a QRS, and is every QRS preceded by a P wave? You can look at the QRS, is it wide, is it narrow? And then the ST segment, the T waves, etc. And I think that's sort of the core of everything I do. And then anything that seems to be abnormal there, you might dwell on it a bit more. So if there's, say, an abnormality in one lead, you'd look at the reciprocal lead in the same territory.
I mean, to be honest, I'm really impressed. You know your stuff. I've met different. Are you a third year?
No. It's Steve. I'm the. It's Steve.
Sorry. Yeah. Well, yeah. Brilliant. That's. I mean, obviously, you know your stuff there, so I'm very happy with that. So I guess for this one, Steve, you'd help me out if you just talk me through basically on this ECG using that process.
Yeah.
What we're seeing.
Yeah, absolutely. So as we said, start off with the rate. So a couple of ways you can do it. You can count how many QRS complexes there are if it's a 10-second strip, or you can look at the distance between your RR interval, and however many big squares there are, you can do that. 300 divide that number. I guess this is probably just under 3 squares, so 300 divided by slightly less than 3. The rate's just over 100, so they look tachycardic. The rhythm, so where's it coming from? Looks like there are P waves preceding every QRS. Looks fairly regular, so it's sinus. The axis, so 1 and 2 in AVF are all upright, so it's a normal axis. And then you can look at the waves more specifically. So we've already looked at the P and QRS complexes as in association. There's a narrow QRS, as we said. It's not wide. The so the ST segments, they don't particularly look elevated in any of the leads that I can see. And yeah, the sort of good R wave progression. So I mean, it looks like sinus tachy.
Yeah, and you're right, absolutely. So this is basically an easy, very, this shouldn't all be hard at all, but this is just getting people to think about how to interpret it. You followed that that process there to interpret an ECG. So I've created some reference things there. So just to go over that quickly. So you should see here on the right, that basically a quick summary of that. So yes, you're going to include all your patient detail. It's very important. Fortunately, I can't include that on here, but that is absolutely bang on. You're absolutely right. You should do that. But when you're getting down to the ECG itself, yeah, you're looking at your rate. And as you say here, you can look at here for the number of big squares. So typically using this as a reference here, you can see that it should be 1 square is 300, and you divide that by the number of big squares to get your number of to get your heart rate. And that's the way I generally do it for a regular rhythm. If you're getting something which is a bit harder to do, or maybe even slower, you can count up the number in a 10-second strip and times that by 6. By times that by 6, you get there within 60 seconds, and that's your rate over a minute. So absolutely, yeah. Then you're talking about your axis, as you quite rightly pointed out. This is a normal axis, and you can spend an entire session talking about that. But something I would try and point out for everybody to try and think about considering in the back of your mind is this little diagram here. And if you can understand this and have a go at practice drawing this out, it actually makes a lot more sense to what an ECG means, because you're looking at electrical activity moving away or towards these leads. So that said, with an axis then, your cardiac axis, there should be, there it is, it's moving now. This is your sinus node, it's moving down here in this direction, isn't it? The electrical activity is moving from top left to bottom right. So that's the direction of a normal cardiac impulse. And that's why you should be able to see that in leads 2 and 1. It's what you'd expect in AVF as well. So because it's moving that way towards these leads in general, that is just a snapshot of how you interpret axis, but that's what you're looking for. And in this here, that is what's happening. In leads 1, 2, and AVF there, they're all positive. And then you move on to your P waves, as you said. So you're looking for, are there P waves? Yeah, you can see P waves. Are there a P for every QRS? Yes, there is. What is the PR interval? That's another thing you want to consider, because it's when you start looking at your heart block. And the big rule of thumb is that normally you're looking no more than like 160 milliseconds. But the way I really look at it, if you're looking more than one big square between the start of the P and your QRS, then you're looking at prolongation there. So that's something to bear in mind. Again, heart block's a whole other topic to consider. Your QRS here, as you said, is it narrow? Is it broad? And you're looking if you're thereafter, if you've got any ST elevation or depression. And T wave morphology, is it inverted? Not. And one of the biggest things that I've generally found that we all miss out, including myself, is a QT interval, which is particularly important for patients who risk with this. If you prolong QT, you're much more at risk of having dangerous arrhythmias like VT or VF, and you can actually have some congenital conditions as well, which make you more prone to those. So don't forget your QT interval as well. All right. Okay. So that's a snapshot then how you interpret an ECG. This is a way of assessing a tachycardia to consider as well. So you should always do your standard as you can, following that method, but you should also consider this as well for when you do have a tachycardia, to how to interpret it. And basically these 4 characteristics can help steer you towards what you're looking at. So the first thing is that if there is a tachycardia, so the heart rate is more than 100, you want to know, is it a narrow or is it wide complex tachycardia? Now we know that's a narrow complex there. Is it regular or is it irregular? The one we just saw there is regular. Are the P waves present? Also, and morphology, which we're going to come to in a bit as well. And here you can see that, yeah, there are P waves. And is there a P for every QRS? Yes, there is. And sometimes you also want to think about, is there more Ps than QRSs? Or is there more QRSs than Ps? And this will all direct you into sort of an idea of what you're looking at on that tachycardia. So what could this be? So using that formula, yeah, as I've already said here, I've pretty much summarized that. It's narrow, it's regular, there's P waves, there's PQRS, it's sinus tachy. The other thing to point out about sinus tachy as well is that because you're actually having the sinational node send this down in this direction, if you're looking at your leads here, you should see that it's moving towards lead 2. So your P waves should be upright in lead 2 and lead 3, lead 2 and 1. And that's what we're seeing here. So in lead 1, it's positive, and lead 2, it's positive. Similarly, another big thing is that if it's moving away from lead AVR here, so this signal is moving away from that lead and therefore should be negative. So if you're looking at your P waves, they should be negative in AVR. And that also indicates that this is sinus. So lots of causes of sinus tachycardia. The scope isn't really to go through that. There's loads. Something to be aware of is that when you are looking at sinus tachycardia, you can see the P sometimes encroach on the T, and that can give you this sort of camel hump appearance. That's something to look out for. In terms of the actual causes, though, yeah, you've got loads: anxiety, pain, being septic, having PEs, hypothyroidism, drugs calling it. So really what you think about here is you need to do a full assessment. So if somebody's got sinus tachycardia, you need to think about your history, exam, your investigations to really look at what's causing this. And I'll say no more on that. Let's move on. Next, ECG. Does anybody want to have a go at and trying to interpret this one at all? So I'll tell you what, I'll include this on here to help you out. To maybe encourage somebody to have a go. Anyone?
If anyone's not, if their mic's not working or prefer to put in the chat, feel free to do that as well. We can always liaise from there.
Yeah, that's fine. It's we can talk through it together anyway. This is an opportunity for you to have a go, and we'll talk through the ECG together as you're going through. Okay, no worries. So that's fine. So we'll talk through it together then. But if anybody does want to have a go, please just voice in. All right. What we got here first of all. So obviously you're going to do your standard checks that you're going to do. I'm just trying to move things around so I can see things. There we go. You do your standard checks as have already been talked about your name, the date, the patient's details are correct, that the trace is actually set to the correct speed. But then you're getting down to the nitty-gritty here. You're looking at the rate here. And we can see here, generally speaking, I look at the rate and rhythm first, and I can see straight away that this rate is fast. And I know that because one big square, the RR intervals between them is 300 beats per minute, and 2 squares is 150. And I can see here that, well, this looks like it's somewhere around 150. This one here looks almost like it's encroaching between this, about somewhere about maybe 225. But what I'm really noticing here, other than the rate, is that the rhythm definitely doesn't look regular looking at it. The RR intervals is definitely different. So that is a big clue what's going on here as well. Next thing I'm looking at is my axis, and I can see here the axis, as we've already talked about, that the axis it seems to be normal axis because it's moving towards your leads in your standard horizontal downward to the bottom right direction of the heart in that picture. So we can see it's positive in 1, 2, and AVF. Then we're looking at our P waves. That's the biggest clue here, guys. I don't think, can anybody see any P waves? And we're going to assume that everybody is all at home and going, no, I can't see P waves. So that's already making people think what this could possibly be. Is there a P for QRS? Well, you can't work that one out. Is there a PR interval? Well, you can't really work that one out either. In terms of QRS duration here, definitely I would say looks narrow to me, it's not broad. And then R wave progression was something which I should have talked about a bit before, actually. Unfortunately, when I'm looking at the screen, this is sort of blanked out on one side because I'm looking at names and chat. But your standard R wave progression, you should be looking at your leads are moving from negative to positive as you move through your chest leads. That's V1 to V5 or V6. So by V3, you should really be looking to transition over. What's about that? So, and then the ST changes here. So something else to look out for here is touchy some ST depression. So we can see here, particularly in these lateral leads here, it does look like there's a bit of depression going on here. Not a lot, but a little bit. So what is this? I mean, this is one way of looking at there, but I'm going to use this other algorithm at the moment. So we can use this. Is it narrow or is it a broad tachycardia? It's narrow. Is it regular or is it irregular? It's irregular. P waves, and what's their morphology? Well, we can't see any P waves. Is there a PQRS? Well, that means nothing. We've got no P waves. So what could this be? Can anybody maybe put in the chat just to make me feel a bit better that there are people out there what this is?
Had a few suggestions in the chat already, Tim, and I think someone's just asked the question as well about lead 1. They're asking, is that not a P wave, or is that, are they mixing it with a T?
You're probably talking around maybe this thing here.
Lead 1, not V1. Sorry.
Oh, lead 1. Sorry.
Yeah.
Okay, lead 1. Okay, no. You're right. So it's hard, isn't it? So it's going to be at first. I would probably say that is a T. I would probably say anything, but it's harder when the heart rate gets faster. It's harder to distinguish your T's and your P waves and your QRSs because everything just gets squashed together. And that's we're going to come to that actually in another example soon because this is reasonably fast, but you can get a lot faster. And that's when you're really struggling to work out what those are. But the main thing we're saying is that generally speaking at the moment, we can see that this is irregular and generally looking across the trace, there is no real consistent P to QRS at all. Okay, sometimes with AF, you can see occasionally what looks like a P wave. But if you're generally looking at an irregular rhythm where there is no obvious consistent P waves going on, you should really be thinking that this is AF. And that's right. I can see that people have put that in the group. So well done. Yeah, this is atrioventricular. So this is atrial fibrillation, sorry, with a rapid ventricular response. Okay, so well done. Brilliant. Okay, so management, well, I'll see if we can skip over that. I don't want to take up too much time, but really, as I'm saying at the moment, it's a quick pathophysiology. You're getting a lot of chaotic activity in your atria at the moment. It's just chaos up there at the moment. And they're trying to transmit signals to this atrioventricular node haphazardly. So this is just picking up signals as it's being fired at from all directions from these signals. And that's causing you to have this irregular conduction down your ventricles to give you the irregular rate. As you'd expect, because it's just so chaotic in here, your sinus nodes are being basically drowned out by all these fibrillatory waves. You're not going to see any P waves there at all. So that's a quick overview of AF. In terms of your treatment, you've got loads of things you can do here. You've got rate management, where you can use your beta blockers. You've got your rhythm control, which can shock them, or you can use things like flecainide or amiodarone to try and convert them pharmacologically. If you really have a patient that just can't deal with this, you can pace and ablate them. So you just literally burn off this atrial ventricular node here and become completely pacemaker dependent, so that the patient will still stay in AF. AF is still going on, but basically it's not being conducted down anymore. If they're really unstable, you're going to shock them. And another very important thing you should try and consider here is your anticoagulation, because, well, I guess, can anybody say what the biggest risk, I guess, in terms of thinking about anticoagulation and why you need it is for AF? Maybe put it in the chat. I'm trying to scroll through. Yep, stroke clots. Yes, you're right. So the biggest one we look at is definitely a stroke, but really you're talking about a thrombus here that can be basically made generally in the left atrial appendage here, which can basically be fired off from your heart anywhere. Definitely could go to your brain. It's a good blood supply that goes straight from the heart to there. But technically it could go anywhere to cause infarcts, but stroke is one of the big ones we worry about. So anticoagulation is important for these patients. And depending upon what you can try and use warfarin, or if we can, it's non-valvular AF. So that means that it's not mitral stenosis more than anything. Mitral stenosis is the big one that makes you valvular AF, then you should be able to use a DOAC. Let's move on because I'm conscious of time. So, right, yes, our next one, this is the prompt for the next one. This is my next ECG. Dare I ask if anybody would like to have a go at interpreting this ECG? Go on, somebody be brave.
I don't think we've got many takers, unfortunately.
No, that's fine. Well, we'll carry on then. The main thing is the process here. So I guess we're talking here then. So we can do the usual thing. This is fast. This is a tachycardia. We can see that it's roughly, try and look on your ECG. You try and find something that lines up with a start of a grid, and you can use that to try and work out what you're doing here. And we can see that this is within 3 big squares, which means that this is going to be over 100 beats per minute. So that'll be 300, that'll be 150, that would be 100 beats. You're probably looking about 125 going on here. Then, so the first thing you try and do is your rate. So we've already established it's probably around 125 beats per minute. But yeah, and then you look at your rhythm, and from what I can see here lining up, it looks pretty regular to me, which is good. Axis looks normal, as we've already talked about. Deliberately try to choose ones with normal axis to not confuse things, so they're positive here. And then you're looking for your P waves. Now, I guess here's a leading question. Am I seeing P waves at the moment? You can put it in the chat, people. Am I seeing P waves there? Okay, yeah, we've got a yes. Yeah, okay. See, let's see if we have somebody else who wants to confirm with that as well. Anybody else think yes? Yeah, okay, no worries. Well, you couldn't be blamed for thinking that, to be honest, because yeah, you can see what looks quite clearly to be a P wave, can't you? You can see here, that looks like a P wave there. You can see that looks like a P wave there. Oh, there's a P that's followed by a QRS. So, well, yeah, I mean, yes. So somebody's put in the chat, it's inverted. Exactly, it is inverted. It is different. So we need to think about, well, let's finish the ECG first, and then we'll come back to that, because you're right, there is something different there. So in terms of your normal interpretation here, yeah, we talked about the rate, we talked about the rhythm, we talked about P wave. We see something that looks like a P wave. Yeah, it is followed by a QRS. Yeah, the PR interval looks very, very small to me. It looks like almost instantaneously after it that there's a QRS. The QRS looks narrow, and in terms of my ST segment, it looks fine to me. I'm not seeing any ST elevation depression really at all. Nothing significant anyway at all. Again, the thing is about the presentation, this guy's had palpitations, but you know, we're obviously with more history to see about chest pain, but there's nothing here that makes me think that. So one person can say that, yeah, this looks like a sinus tachycardia to me, but the P waves are different from normal. Now, we talked about with your normal sinus rhythm, it's coming from our synovial node, moving to the atrioventricular node and down. So it's moving in this direction. Okay, can you guys see my pointer, by the way? Just make sure I'm not imagining this. Can you see my mouse pointer?
We can see that clearly, yeah.
Yeah, good, yeah, brilliant. It's moving this way. So it should be moving away from AVR, yeah? Which means that AVR for a sinus beat should be negative. But AVR has actually got these little positive bits here. It's got positive waves here. Similarly, you think in lead 2, it's moving down towards lead 2, so therefore it should be positive because it's moving towards that lead. It's moving that way, it's going to be detected by this lead as a positive deflection. But when we look at lead 2, it's negative. So can anybody maybe put in the chat what they think maybe what this is? Let's have a go. I'll be impressed actually.
There's a hint where it might be coming from.
Yeah, so somebody's put a juncture rhythm. Yeah. I couldn't be blamed for thinking that. I guess my thing is at the moment, we can all agree that this is not sinus though, isn't it? It's not sinus. Where do we think it's coming from? Somebody's put junction also, I guess by that, that's one thing. Yes. Yeah, well, yeah, fine. That's good. Somebody's put atria and an ectopic. Yeah, it could well be. But the key thing is at the moment we're saying here that this is not from the sinus node and we're thinking it's coming from the atria. Yes, absolutely. So what is this? We can use our little formula here anyway. This is just to try and help us think about what things are. So is it narrow? Is it broad? It's narrow. Is it regular? Is it irregular? It's regular. Are the P waves present, and what's their morphology? And that's why I've added in that morphology, because it really makes you think. There are what looks like P waves, but we've established that the morphology is different here. Okay. Then, is there a P wave for every QRS? Well, there actually is, but it's not. Again, we're not sure this is a P wave. So what is this? So this is just an idea to make you think about what things are. So we've decided this is coming from the atria and not the sinus, somewhere else. So this is actually an atrial tachycardia. In specific, this is actually a focal atrial tachycardia. And that means, hopefully you see this little spot here, that this is coming from elsewhere than it actually is coming from the sinus. So we're getting a thing that's giving a P wave similar from a specific site elsewhere in the atria, which is firing down to the ventricular node. Now, when you get really sort of clever in cardiology, like you can actually work out where this is coming from depending upon your leads. So in this particular example, we've established that lead 2 at the moment is actually negative deflection, which means it's probably moving, it's moving away from that lead. So it's probably more likely to be down here than anything towards this AV node. But the key thing I want you guys to walk away with is that this is not sinus. This is an atrial tachycardia. Okay. And the atrial rate, by definition, is going to be greater than 100 beats per minute, and there's abnormal P waves that are present, okay, particularly in their morphology. The key point is you're going to get an isoelectric baseline here, okay? So another very important thing of this is not only are there abnormal P waves, but you do get a flattening between your P waves, okay? This can be caused by generally overexcitability of your heart. There can be lots of reasons for that. It can be injuries to the heart, like ischemic heart disease, stimulants, alcohol, lots of things that can cause this. But that's just what I want you to try and recognize at the moment. In terms of management, generally speaking, for most of these, is that you can try and beta block them or calcium channel block them to try and dull that down. And if things really do get bad, then you can consider a catheter ablation. Moving on anyway. Now this is the ones that we really want to get to. This is the ones where we're getting abnormal ECGs here. So this is a 56-year-old lady who's come to ED with palpitations. These, from her history, is quite important to this diagnosis, that these are sudden onset and offset palpitations. She feels like a very fast heart rate, as she would, because you can see this is fast. She's short of breath and she's anxious. She's had this for 5 years and she usually just gets on with it. It just sorts itself out. She's hemodynamically stable at the moment. And what could it be? So this is using the system here where we go. So I'll save time. I won't let people have a go at this, but I think everybody can appreciate that this is fast. You can see from this heart rate here at the moment that, as I say, it's within 2 squares. So it's greater than 150 beats per minute. It's less than 300. Again, probably, I mean, so that'd be 150, that'd be 300, or maybe 200 beats per minute, maybe around that. I mean, I would probably consider adding these up in times in line 6, but either way, it's fast. I think we can all appreciate that. And this is when we were talking before that it's very hard to work out. Is this a P wave? Is this a T wave? It's just too fast to work out. So using our little tachycardia algorithm here, just to help us through, we should think, is this narrow or is this broad? I guess we put in the chat first. Do you think this is narrow or broad, guys? Yep, good. I can see I've got my little chart here. I can see that. Brilliant. Okay, so is this, I think somebody's put a thing in, but fair enough. We'll say it's narrow. Moving on. Next thing in our little algorithm here, is it regular or is it irregular? So we just want to write in the chat. Yep, it's regular. Brilliant. Are there P waves? Well, I've already kind of answered that one at the moment. It looks like it's written. The honest answer is it's hard to tell. I mean, what are these things here? It's going so fast we can't tell if that's a P, a T wave. You don't know is the short answer. So we can't really obviously see them at the moment. And we can't really work out our P to QRS. And this is where we think to ourselves, well, this is going too fast for me now. I can't really work out what this is, but I know it's narrow complex and I know it's going fast. So it's a narrow complex tachycardia. So here's my question at the moment Well, what can we actually do to try and work out what this is? In terms of maneuvers or drugs, anybody maybe put in the chat what they think it could do? Yeah, absolutely, a vagal maneuver. Yep, you can do that. Adenosine, yep. Carotid massage, all brilliant ideas. Yep, guys, that's great. Those are the ones I'm looking for. So this is when we start using onto our this is actually the ALS guidelines here, which is generally what you should always sort of consider. I don't want you to feel like, oh, I've got to study all these here. Don't worry too much about it. I'm just going to point out the key points, okay? Now, if this person was really, really unwell, then you're going to be looking at shocking them. That's it. If this patient was, you're looking at them, they look awful, they're in shock, they're unconscious, they're in severe pain, which you could argue with this patient here, they're having some SD depression here, that it might actually, look like they need that. But we've already established that the patient is actually generally all right. But this looks like, from the SD depression, that there could be some myocardial ischemia going on here. So we could consider shocking them. But the next thing we could do otherwise is actually moving that. Nope, they're stable. We've established that this is a narrow complex tachycardia, and we can consider some maneuvers to try and do that. And one of them we've established is your vagal maneuvers. So you've talked about your carotid massage. That is definitely one you can do, but you need to be careful with that one, particularly with your older patients or vascular paths, because massaging those carotids, you could dislodge something up there and cause a stroke. So that's one you want to be a bit careful about. The Valsalva maneuver, modified Valsalva, is another one. So maybe you've heard about people being given a syringe to blow in. That is another one you should really try. So your first things you should always try and do to slow people down is probably going to be that, the modified Valsalva. You give them a syringe to blow into, they're basically bearing down whilst they're trying to blow into this. And what you can do is lie them back and lift their legs up, and hopefully that should slow them down. Failing that though, you're going to move on to your adenosine, and that's when but rather than go into the nitty-gritty of how many doses you give and what you give, adenosine is the drug you're going to consider here. And if that doesn't work, then you're looking at your beta blocker or verapamils, okay? Key thing is, if you do use adenosine to try and slow this down, it's a transient source of block you get on the atrioventricular node there, so you're really going to want to think about having a continuous ECG trace running, so you can actually record what's going on, okay? But let's just say for this gentleman here, or this lady, should I say, we've given her some adenosine. We tried the vagal maneuvers, it didn't really work, they never really do. We'll give her some adenosine, and that's what we've got here. Now, without, I guess, straight away, people, spot diagnosis, what can you see here? Just as a rhythm, just the rhythm I'm interested in. Oh, yeah. Oh, no, it's, so somebody's put flutter. I can see where you're coming from. You could be definitely forgiven for that. Yeah, somebody's put sinus rhythm. You're right. Now, I know why somebody's put flutter. It still is going a bit fast here, isn't it? It is actually just under 100 beats per minute, but it's definitely come down from what it was. And it's because it's starting to encroach the P and the T wave here. You can see the P wave slightly smaller than the T. Those two do look like there's no sort of isoelectric baseline. So I do forgive you for thinking that. But if you do look elsewhere, you can see that there is an isoelectric baseline here. So yes, this, and it's also, isoelectric baseline. That's the main one. So no, this is normal sinus rhythm. So I guess here's a question for you. Can you think of any rhythms that you go very fast, a narrow complex tachycardia that you used adenosine on, and that's now brought you back to normal sinus rhythm? Anybody put in the chat what they think such a rhythm could be? Go on. Yeah, exactly. Yeah, brilliant. So at your level, yes. Where are we in here? So this is what was the rhythm then? Yep, atrioventricular nodal reentry tachycardia. Well done. So what is that? Well, we're basically, I think, rather than getting into the two nitty-gritties of this here, this person in, we're talking here about a re-entry circuit, which is occurring at the level of the atrioventricular node. So you've got a signal which is basically come down. There's an abnormal conduction. This is your pathway that's coming down here for your ABN. You have a fast pathway and a slow pathway, and these two sort of work in tandem to produce a signal going down. Now, I'm really going to make this as basic as possible because this is something for physiology, which hopefully you already know, but I would just go and watch a YouTube video. Otherwise, osmosis is pretty good. You want to look at your slope. You've got two pathways here. Now, if one of these sort of finishes a bit earlier than the other, what should normally happen is that you have these two pathways meet at the bottom here and carry on. So you've got two people going down here, they bump into each other and they carry on going. But if you have one pathway which for some reason or not is a bit faster or slower than the other than normal, then you get this action potential around here gets reset up. And then basically what you can do is you can basically have one pathway going round, and as well as going down, it can come back up because this is ready for a new signal before another one's arrived. Effectively, it just goes around. So, I mean, that's the really basic way I'm going to say that. Effectively here, you have a signal that is able to go round and around and around because one of these two sides is basically out of sync with the other. Okay. So the key features here is that you get irregular complex tachycardia. You got P waves that are actually going to be hidden in the QRS. So there is P waves, but you just can't see them because basically at the moment you've got this circulating upwards here, following this arrow and going downwards. It's all happening at this level. And the ventricle, because it's just bigger electrical signal, bigger voltage, is basically overshadowing the atrial event going up here. So your P waves are hidden. So key things of AV and RT then, you've got P waves that are hidden in the QRS. It's generally rapid onset and offset is what you're looking at getting. It's generally triggered by some sort of ectopic sort of focus. And you get termination with your adenosine or vagal maneuvers. So well done for those who got AV and RT, well done. So investigations and management, I'm going to move on. Don't really have time for that. We've already said that you can cardiovert with adenosine, beta blockers, or CCBs. Here's another one. I guess we'll do this one quick together. So what we're looking at here, so we've got our tachycardia algorithm because this is going fast. We can see again that it is going greater than 150 beats per minute, again, somewhere in the 200s. Is it narrow or is it broad? Go on, guys, put in the chat. Just literally put narrow, broad for me. That'd be brilliant. Excellent. Yeah, narrow. Is it regular or is it irregular? Yeah. Are the P waves present? Well, I'm going to leave you that. You can't really tell. It's too fast again. You just can't tell. Okay. P to QRS, you can't do it. So what else are we going to do here at the moment? We've established we've got a narrow complex tachycardia here. We're going to follow our little ALS algorithm that we had up there. We've got two things we can do here. So if they have syncope and chest pain, what am I going to think about doing for this patient? Let's put in the chat, guys. Yeah, exactly. Brilliant. Excellent, guys. Brilliant. You're going to cardiovert them. Yeah. If they're what about scenario 2? Already sort of just covered this. What we're going to give, or what we're going to try even. Yeah. To be fair, yeah, that I was leading question. Yeah, you should try your vagal maneuvers first, and then adenosines. So we've done that. We followed our pathway. In this particular case, we've gone down the adenosine route, and that's what you've got now. So, I mean, it's kind of a spot diagnosis, actually, really, isn't it? So, I guess what I'm going to say here. So, describe this ECG. Again, we're running short on time, aren't we? Let's just talk about it. What is this? Go on. Somebody put in the group. What is this? Exactly. Yes. Thanks, Stephen. It's atrial flutter with variable block. So here we definitely have our flutter waves here. We can see them. There's no isoelectric baseline. We can see that the atrial rate here, these inverted commas P waves, a much greater rate that's greater than the ventricular rate. There's no isoelectric baseline whatsoever. And we've got this variable blocks. We've got this 1, 2, third one's conducted, 1, 2, second one's conducted, 1, 2, 3, maybe 4. Conducted. Got a variable block there. So atrial flutter, atrial rate is faster than the ventricular rate. You get your sawtooth pattern here, and you've got your atrial activity, which is going at 300 beats per minute. So you can see here that these atrial beats here, we're almost pretty much within one big square. They're going at 300 beats per minute. And in this particular way to appreciate it, you've got a variable block going on here. So you Brilliant. That's great. So in terms of treating this, you've got your ALS algorithm. So adenosine will slow it down, but it'll just generally speed up again. What you're going to try and do here is you're going to try and beta block them. That's what you're going to try and do. If you really can't do that, you're going to try a calcium channel blocker. All right. So I should have mentioned, so adenosine and beta blockers, you want to be a bit careful with people who've got asthma or asthma type conditions. So a calcium channel blocker is something else you can think about. You're going to want to anticoagulate these patients as well. And really the biggest treatment for these patients is a radiofrequency catheter ablation. Just collect on that. This is basically showing, this is the circuit that's going on here. So this is described as a macro re-entry tachycardia, because it's going across the entire atrium up here. So rather than being at the node, this is across the entire atrium, and hence macro re-entry. Okay, this one here. Again, I know we're a bit short on time here at the moment. So looking at this ECG, what have we got here? We'll just follow our tachycardia algorithm. Is this narrow or is this broad QRS? Let's put in the group, guys. Narrow or broad? Yeah, brilliant. Yeah, oh yeah, we're skipping ahead. It's regular, brilliant. We're all catching up. It's regular. Can you see P waves? No, not really. Can't really see them at all, can we? P waves QRS? No. So we need to slow this down. All sorted out. Now, if this patient was unwell, hemodynamic unstable, or stable, I think hopefully my next slide should do it anyway. Yeah, we're going to look at our ALS algorithm. So they're unstable. You're going to shock them. Otherwise, you're going to proceed down to our QRS. It's narrow and it's our regular tachycardia. So we're going to do our vagal maneuvers before. Now, this is something I do want people to have a go at interpreting. This is the results. You've given some adenosine and that fast heart rhythm, and now this is what you've got. Okay. Can anybody tell me, if they don't want to point out what's going on, can they tell me the key features of this ECG? Yeah, okay. Yeah, brilliant. So people are picking up on this. Excellent. So brilliant. People are seeing that this is they're seeing the delta waves. Yes. So people are putting WPW in. Yeah, that's right. So this is basically a Wolff-Parkinson type ECG. First of all, is there a tachycardia? No, we've terminated that tachycardia. The adenosine has worked, but it's unrailed something else under here. So we would now, because this is no longer tachycardia, we revert to our standard ECG interpretation. And the key features that we're getting from this ECG is what people have pointed out here, is that we're getting this characteristic upslowing here, this delta wave. We've got a short PR interval here. So the start of this QRS here is actually shorter than you'd normally expect. And you've actually got some evidence of some changes here in your T wave, which is moving the opposite direction. So this is what you're generally looking at. They talk about a sort of a slightly prolonged QRS as well. So, I mean, greater than 110 milliseconds really, but it's really the key features you're looking for is your short PR interval, your upward slow of your delta wave, and maybe some secondary T wave changes. So yeah, well done for spotting that, guys. So I guess what is actually causing this then? So this is AVRT. So it's easy to get them confused. So NRT obviously involves the node that we've talked about, whereas AVRT, can somebody put in the chat, what is that talking about? What's the main principle of AVRT that's causing that? What causes Wolff-Parkinson-White in terms of the physiology? Yeah, well, somebody's very technical there. I like that. Yes, well done. Bundler Kent. Oh, I accepted the accessory pathway, but yes, well done. So this is what we're looking at, our accessory pathway. So Wolff-Parkinson-White is an example of accessory pathway. We've got here our normal pathway. So it's coming from our sinus node, going to our atrioventricular node here, where there is actually a brief sort of pause. And you can appreciate that by having this isoelectric baseline here. And then that gets conducted down into the ventricles to cause your normal conduction. So this is your P sort of baseline QRS. That's what you normally expect. And that's what's happening in this Wolff-Parkinson-White. So that is still occurring, but at the same time, you've got this signal which is coming down through this accessory pathway. And that's both appearing on the ECG at the same time. Now, when you conduct through your accessory pathway, that's not going down your motorway. You designed conduction pathways. This is going down your back roads, which is going to be slower. And this is why here you can see that there's a slowly up slowing going on, because this depolarization of the ventricle down here is going to occur slower than your normal highway conduction here. That's what's causing you to have this upward slurring here. So what you're seeing here on this delta wave is a combination of your accessory pathway conduction and your normal nodal conduction. Now, the key thing about this is this can go in both directions. And that's what sets up your here for your AV and RT. And that's what you're getting here. So, it's not giving me a little spinning thing, which is annoying, but you can have two ways this goes round. You can either have this going one way. So this is going down the atrioventricular node here, down your normal pathway, and then back up the other side. And because this is using your atrioventricular nodal pathway here, down your highway, it's going to give you a narrow complex. So it's hard to appreciate. You can see definitely compared to this one here, it's a narrower complex. Okay. However, if this is going down the other way predominantly, in the center of this loop that's been set up with this AVRT, it's going to go down here and depolarize slower. And because it's depolarizing slower, you're going to get a broader QRS, which is then going to go back up your AVN and happen again. So you've got these two different ways that you can get AVRT. So the one that we were seeing was a narrow complex tachycardia. So I guess, well, this is just a little picture here we can see here just to demonstrate what I'm talking about. You can see going, first of all, down the AVN, up and up the accessory pathway. So this is your normal orthodromic pathway to give you a narrow complex. Whereas here it's going up, down the accessory pathway, sorry, first and up the AVN to give you broader. So before I talk about this, I guess, what would you people say this ECG is then? Just as from what we've been talking about. Can you put in the chat for me just what you think? Yeah, so somebody's put antidromic AVRT. Yeah. I guess you could think that. You could, looking at this ECG, you could say this is narrow. Oh, sorry, it's not narrow, it's wide, of course. This is a wide complex tachycardia. It is regular. There's P waves. Well, it's really hard to appreciate them. I would struggle in an emergency situation. P to QRS ratio, I'm not really sure. So what am I going to do with this? Well, the answer to your question that yes, actually, this is actually a an antidromic AVRT, but for your sake, you're going to treat this as VT until proven otherwise. I saw this. I'm considering VT. I wouldn't chance it unless you're really confident. Now, the reason this could be AVRT is that this is a young person, young boy, young people, boys or girls don't generally have VT unless they've got congenital heart disease, and he's got known to have Wall Parkinson White. So in this gentleman, you could think that, yeah, okay, this probably is an antidromic AVRT, but I would definitely, basically, your level guys, treat this as VT. So what are you going to do in this situation? If you saw this ECG, you can put in the chat, what would you do in terms of, let's just say, you know, in terms of the management? Cardioversion, yeah, that's right. That's your safest option here. So, and you're right, somebody's talked about here fusion beats or capture beats. Yeah, good. You obviously know, looking at your AVR, you'd be looking at your algorithm for looking at VT. So well done. But yeah, in a chance situation, you're just gonna basically give some sedation to this patient if required, or potentially intubate if needed, and shock them out of it. That's the safest thing you're going to do here. However, saying that though, oh yeah, this is just your pathway. So yeah, I'm saying you're probably going to shock this patient. If you're in doubt here, you could try amiodarone here. Now, amiodarone is a drug. This is domestos of drugs, really, but that also has an effect of acting on your AV node as well. And there's a reason that makes me a bit nervous about using amiodarone in this sort of case if it acts on the AV node. And I'm basically going to illustrate that by asking you guys for this last ECG of the evening. So I am very conscious of the time, guys. We are going to finish in a second. But this ECG here, okay? Looking at this ECG, we're going to just interpret this quickly. I guess for somebody in this ECG, would you use adenosine or a beta blocker here? Let's just see what people think first. Have a go. If I said to you, oh, should we use some adenosine on this patient to work out what's going on? I know somebody's put question mark adenosine. Yeah, okay. Well, if I said to you, shall we use adenosine? Would you say yes or no? Okay. Well, I guess in the interest of time here, I'm going to say you could try it. Okay. The answer is actually no. You don't really want to use it. And I'll explain in a second. So this is a narrow complex tachycardia. Sorry, what I'm talking about. This is a broad complex tachycardia. We talk about narrow complex D1. This is definitely broad complex. Is it regular? Is it irregular? It's irregular. We can see here that the RR intervals here are very, very different from each other. Okay. And that immediately makes me quite worried with seeing an ECG like this. Are the P waves? Again, I guess at your level, it's very, very hard to work out if there are P waves. And in a situation like this, I wouldn't really want to stick around to find out. Is there a PQRS? Not really sure. So one argument is yes, you could use adenosine to try and slow this down and see what's going on. However, this is what we call pre-excited AF. And this is basically where we've got an accessory pathway here with our IF. Now, the problem with that is you've got this chaotic ventricle up here with chaotic atria up here with all these signals firing up at the moment, just fibrillatory waves. And you've got the two pathways at the moment which are working together. One of them will probably be more dominant than the other. And you've got these conduction, these fibrillatory waves coming down, hopefully dominantly by the AV node is what you'd be seeing, but they're also coming down here by the ventricle as well. And that's what's giving you the broader complex here. Now, if you suddenly block that off using your adenosine or your beta blocker, which acts on your AV node here, then you're pretty much opening this pathway up to be your main one here. You've got people trained to get through this road here. You've got a bouncer on the door here who's sort of slowing people down, saying, no, one at a time. This is your fire exit here, which is open and people trying to get through. If you block that off, then everybody's just going to go straight through here. And you're taking these fibrillatory waves here all the way down into your ventricle. So what would be the consequence of that then? Somebody put in the chat. Consequence of these fibrillatory waves conducting down through this accessory pathway into your ventricle. So I see a question here from, yeah, so I'll come back to that actually. So somebody's asking, so you turn orthodromic into antidromic. I'll come back to that, but just in terms of, yes, somebody's put VF, pretty much you're basically taking fibrillation effectively. This is effectively what you're doing here, taking the fibrillatory waves conducted straight away down into your ventricle. The main thing I'm saying is you're basically getting a very fast atria, which has been conducted directly without any form of bouncer here to slow your heart rate down straight into your ventricle, and that's going to stimulate you to have effectively ventricular fibrillation. If this is potentially another atrial tachycardia, you could get a VT type thing down here as well. So VT, VF, not a good idea. So that's just something to be aware of. So if you see somebody who has a background of Wolff Parkinson White with an ECG which shows AF, you definitely want to be careful of this one. And I would basically say the safest thing you're going to do here is shock them. It's the simplest answer there. Okay. I can see just finishing off now, guys. I promise, last 2 minutes. So you're turning orthodromic into antidromic. Effectively, you've got these two pathways here, but you've taken one of them away. And yes, you're basically not creating this. Yes, you are. Yes, absolutely right. Actually, I'm just thinking myself through there. Yes, you are. You're effectively making this pathway dominant, but you're taking the fibrillatory waves straight away through here. So you're right there, Bob. Okay, brilliant. So thanks, guys. This is just a quick summary of just what we've looked at here. So, and to sort of classify some of these arrhythmias. So we've talked about atrial fibrillation and atrial flutter, and we talked about some of the SVTs here as well. So this is your basic real classification of what an SVT is. We talked about atrial tachycardia, atrioventricular nodal reentry tachycardia, and atrioventricular reentry tachycardia. And on top of that, we've also had a look at Wolff-Parkinson's-White's type patterns as well. So thank you very much. Hopefully out of this, you've got a basic ECG interpretation, been reminded about how you review a basic ECG. You've got an appreciation of how you can interpret a tachyarrhythmia, and you've had an overview of identifying these different tachycardias. So there are other sessions that talk a bit more about tachyarrhythmias, and I encourage you to access those sessions as well from previous videos. So thank you very much, guys. If anybody has any questions, I'd be happy to try and answer some.